Hey everyone, and welcome to the Psych to Practice podcast, your one stop for practical and useful clinical information, masterful insight from experts in the field, and a guide to daily living. I'm your host, Paul Wagner, and today we have a bit of a throwback for you, and it's one of the episodes that we have noticed has just been garnering a lot of attention, and so it was sort of a part 2 series, so we thought why not work to combine these and also use it as an opportunity to announce that coming soon, we will be launching a continuing education program for professionals in the field to gain continuing education credits. So far, we have been accredited from the APA and working on further accreditation, and we'll be launching with a video library as well as an approved home study, which is exciting because that gives us an opportunity to review past podcast episodes, and the ones that meet criteria, we can offer a course with an accompanying exam, and you can actually earn CEU credits from listening to the podcast. So keep an eye out on social media as we announce more information and what's coming around the corner for Psych to Practice. But until then, we hope you enjoy the full episode, Case Conceptualization. What is it good for? Absolutely everything. Say it again.
All right, Paul. So back for another Practice in Action episode. And I have to say, I'm kind of excited about the topic we're going to do today because it's one I've kind of really focused on in my career. I've done some writing in, and that's case conceptualization.
Yeah, I think you might have me beat in terms of familiarity, but I think we can both agree it's a really important topic and one that I don't know that is talked about or really understood as well as it should be. So I think hopefully a valuable episode for our listeners.
Yeah, it's not that it's a new topic. I think case conceptualization or a form of that has been around for a while. And I think what's so important about talking about the use of case conceptualization, it doesn't matter, we're going to talk a lot about CBT, but there are versions for psychodynamic therapies. I think they use maybe the term case formulation instead of case conceptualization. And in kind of behavior therapy, maybe they use the term functional behavior assessment. But I think all orientations of therapy have a version of this. And so the idea of kind of talking about what do we need to do to really understand people, I think is going to be important and something I hope maybe we can help people get into practice.
Yeah. And I think a lot of times some of the traps that clinicians can fall into is we focus so heavily on the symptoms. And I think the symptoms are such an important piece. I mean,
right.
That's why someone is oftentimes coming and talking with us and working with us is they're experiencing symptoms, but we can't just focus on the symptoms. And actually you've shared a few different times, off mic, some of the important piece of that. And I was wondering, for you, Ray, how would you conceptualize case conceptualization?
Yeah. It's interesting. I've followed this kind of for a while, and, I really got into it really when I was studying my doctoral program. And, we've said kind of similar stories in the past. It was something I read this article from the Journal of Consulting Psychology. And there was an article by a guy, Gordon Paul, who was a professor in Houston. And he in his kind of article, he wrote this idea of what he called the ultimate question. And essentially the ultimate question is this: what treatment by whom is effective for this individual with that specific problem, under which set of circumstances, and how does it come about? Which is a mouthful, right?
Yeah, no, that was super condensed.
Yeah, right.
But it's complex, but I think that's an important piece because therapy is complex and treatment is complex. And if we think about it in too linear of a way, we miss out on the full experience of therapy if we only are focusing on the symptoms or too linear of a perspective.
Right. Yeah. And it is such a complex thing, but I think the part that got distilled from that ultimate question piece was this idea that our role as healthcare providers or clinicians is that it's more important to really understand the patient who has a disorder or who has a difficulty rather than understanding the disorder or difficulty the patient has. And I always kind of like that term because it really kind of puts that it's not just about what their diagnosis is. Like, I mean, we can get there, but we've all probably had people that we've seen with the same diagnosis, and maybe there's similarities in our treatment, but how we make that unique to treat that person is really the most important. And it gets us beyond this idea that diagnosis is going to give us the right treatment options. I think diagnosis gives us access to the research that we can pull from. And so if I know somebody has a generalized anxiety disorder, in my mind, I can go, okay, I know the research about what treatments work with that. But that doesn't tell me what treatment works with that person. And I think this is really the beauty of case conceptualization, is that we can be thoughtful about a person. We can understand the person and really make it a more personable treatment. And I know, like in my work, and I'd be interested in your thoughts, is that when I've done that with someone, their connection in therapy is different. And, we use the term connection often. And I think part of, the difference in me just talking about exposure from a very research, this works with this disorder. When I talk about it and put it into the context of what that person's experiencing, their ability to have kind of an ownership in using that intervention, or a willingness to use that intervention, I think is greater.
I think some of the, actually quite a few of the Masters in Practice episodes that we've done, we've talked about this. I know with our most recent episode with Dr. E, right. That was a huge part of what brought her into, this, what made her that master. But even, when we were talking with Terry, and she gave that story of someone coming into her office and sharing about, hey, this is what happened and this is where I'm at. And this is why, my suicidal ideation is there. And she was talking about, we know what helps. We know, where we want them to be. But if I were to just share that, and, I think the example was they had just broken up with a significant other. It's like, well, the thing that helps is being more connected than with a different group. But if I just say that's missing the piece, we need to help guide them there. And I think that's the case conceptualization. That's the knowing the person and making it fit for them, rather than just being, a one-stop shop of, just sharing the same information and regurgitating it back.
Yeah, this is not a unique comment to me. I know other people have other versions of it, and I, have kind of stolen and maybe tweaked the comments about, it's really this idea of moving away from one size fits all treatment and moving to what size fits you treatment. Yeah. And which, I think is important, is that, and it does, I think it helps that connection. And when we really think we're doing good therapy, I think that happens. And, whether it's CBT or anything else, it also opens up a door for something else we've talked about in the past. And that's, sometimes we got to go beyond our orientation that we're focusing in, and we have to go, hey, this person needs something a little different. And yes, maybe they have X disorder that responds to this treatment, but for this individual, there's other stuff that's happening that we need to bring into it. So, I think the what of case conceptualization is really this idea of, how do we understand people? I mean, that's beyond diagnosis. How do we really bring that human element and that relationship and connection?
When you were just sharing that this last piece here, I kept getting the mental imagery of having a suit tailored, and my wedding is coming up soon, so that's kind of on my mind. Right. I'm going to butcher this quote. The idea of, you can look better in a cheap suit that you have tailored rather than an expensive suit that isn't. And the idea of like integrating these different, therapeutic backgrounds and styles of treatment, we might not be familiar with them. That, it might feel like we kind of have that cheaper suit, but if we can make sure that we're tailoring to the person, they're going to walk away with a better fit. And, that's what we're doing. We're tailoring treatment to the person and trying to have the best fit that we can.
Yeah, I love that. I think the word tailored is perfect, right? I think that really does kind of summarize where it's at. And when we do that, I don't know that we can go wrong in that approach. And I think an important factor for people new to case conceptualization is the idea that this isn't like an assessment that's a one-stop. I got this data and this is what's happening. What I like about the idea of case conceptualization is we're really weaving this through therapy. And my case conceptualizations honestly kind of change through the process. I have kind of my initial hypotheses about what's happening with people, but as they uncover new things through therapy, it helps me think about their case different. And so it really is this fluid dance that kind of happens where, we have our ideas based on our maybe initial interview or first few sessions, and we have our treatment plan. But as time goes on, it really does evolve. It makes it where it's not this static treatment approach. And we're tailoring it, and then people are gaining weight and losing weight, and we're adjusting the tailoring.
Dynamic with it. Yeah,
we're dynamic with it. That's a great word with it. I think that's important because it makes us personalized. I just keep kind of going back to that. So I guess, Paul, what are your thoughts about? We know being personal with people helps, but how do you think that helps drive treatment? Do you kind of what's your thoughts on why case conceptualization can make the treatment process better?
I think it develops a better sense of buy-in. If I'm thinking about, what are the things that help me, feel I can really kind of be myself, and it's heard and it's seen and it's accepted. What a powerful relationship that can be if you're able to develop that in therapy, where your therapist hears you, sees you, and truly, to the best of their ability, understands where you're at, what you've been going through, how this is impacting your life. And, with that, taking their knowledge. So, the therapist can kind of meet you. So, there's a quote that I in grad school, the patient is the expert in them. We need to be the expert in helping them to be better.
Right.
And so it takes this, we are really trying to be the best clinicians we can. It's impossible to have a cookie cutter approach.
Right.
Even if they're similar, there's subtle differences. There's been times before where I've treated siblings, and even twins, and that was a different treatment approach. And so, for just even their personality, they had those different variations that, hey, I can't just regurgitate the same thing I just said, to their sibling, in our last session. And it was about different things, but that treatment approach still felt very important to make sure that they were feeling like an individual. Because if you just feel like I'm just a number, or, I'm your 10 o'clock session and that's all, then what's the point of coming back? Because you can have a 10 o'clock session. You're always going to have a 10 o'clock session. What makes me different? Right. And I think if we can understand that from the client's perspective, it helps us to feel more motivated to really connect and integrate with them to make this unique experience that ideally helps them to walk away better.
Yeah, I agree. I think connection is definitely one of the reasons we do it. And when I kind of write about this, I always kind of talk about the connection, but also this idea that case conceptualization really helps us gather and organize information. And I know we're going to talk about that next episode about how we do that, but I think it's important that we're really gathering and organizing information to understand the patient's situation and their current problems. So it really, again, kind of builds that connection, helps us understand a little bit. For me, I think the other piece, that I think adds value is good case conceptualization guides treatment.
Yeah.
And so even down to what's the right interventions for the person, beyond just the research, it really is this blend of the science of psychology and mental health treatments and the art of understanding people and how we kind of can take both of those and mesh them together. But when we do that, it lets us again, be more thoughtful in the approaches that we're going to take. I think that's hard. I mean, I think that, one thing I don't want to make it sound easy. I think being good at case conceptualization requires work. I mean, I start my day looking at my schedule and thinking about what I'm doing with people. I think about it before sessions. I think about it after sessions. It really is this kind of part of really thinking about what we're doing, and being thoughtful in what we select, and having the acceptance that we might select the wrong thing.
Yeah.
Sometimes, we make a hypothesis and we go, I think this is going to work. And maybe it didn't go as well as we thought, but then we kind of reconceptualize and come up with maybe alternative hypotheses, which will let us go a different path. So again, I like that selecting good interventions, but also gives us that way to adjust.
I came out of grad school with this broad idea of what it was, but not really how to do it, or at least how to do it effectively. And so just through my own kind of personal or professional readings, trying to adapt, trying to learn that. And even it's a few months ago, I finished one of Yalam's books. I read a few of his over the past year, and I'm blanking on the exact one it was. Okay. It was kind of a narrative story following a psychoanalytic therapist. And one of the things that he had written in there was that this therapist would start each session by, before they went and got the patient out of the waiting room, through my understanding of this person, what is the thing that I can do that's going to be the most helpful for them in reaching their goal or making the situation better for themselves? And I think if we can really capture that, is what we want to do and why, because it's understanding, and it's taking that understanding and applying it and making it better. Because I think we've all at some point felt like a number, or felt like, just another person. But, when we have that individualized specific treatment, it is that tailored fit. It fits us because it was made for us. And it then allows us as clinicians to have that fluid approach that, hey, maybe nope, that didn't work. Okay. But it's this, we're constantly, I think, communicating with our clients as well about it. And I think if we can have an open dialogue about our conceptualization and sharing that with them, again, they're the experts on them. They're going to be able to share that. So as much as I think it's this personal experience for me as a clinician, thinking about okay, what is my thought here? It's also bringing them into the fold as well and saying, this is my working hypothesis, or this is, my understanding of what's going on.
Right. How
does this fit for you? And we're just kind of trying on those different fits until they get one that they're like, yep, no, yes, that's exactly the thing we're talking about. So, and those are the good moments, I think. Yeah.
I like that. I like that Yalam quote. I think Yalam's written, actually, a lot of his books kind of hit on the idea of case formulation in some ways. And you mentioned about the psychoanalytic. I think really, there's a lot of strong roots that come out of that orientation, and kind of going back on what you said about the working hypothesis, which is really the word we use in CBT. I think maybe, in psychoanalytic, it's more providing insight for people, or there's other terms that we kind of use. But I think that's where psychoanalytic has done such a great job in using case formulation and how to give that back to the clinician or the patient, and helping them find that insight and understand those problems. It's interesting when like I said, I think of case conceptualization throughout treatment. That's just part of how my training has been. And I'm always, it always feels good for me when I'm listening, I'm pulling all these pieces together and, being thoughtful in it. And when I do give that back to the person in front of me and say, so we got all this information, and let me kind of distill it down to what I think is kind of maybe happening. And I kind of want your opinion about this. And I'll give kind of my hypothesis to them, and their eyes open, and they give you this look like, oh my gosh, yes, like that's it. Like that's what I'm experiencing. And it doesn't always go that way. I mean, I've had times where I've said something and they went,
you get the sideways look.
I don't think that's right. And that's okay. What a great opportunity for me to go, okay, like what am I missing? Like what what about this can we talk about to give me a different understanding? So there's such a powerful give and take with it. But watching people get it and go, wow, you took all this stuff and it came to this, it gives them a nice little summary, and it gives us kind of a base that we can kind of keep going back to. So I remember the first time I really didn't. I had a little bit of case conceptualization when I did my master's degree, but it was my doctoral training that they really. I mean, that was something that from day one we were constantly talking about, and I remember when I finally started getting better at it and had that moment with someone, and I went, all right, like this was good. Like I got this. It helped me understand the person and helped me move treatment. I think the other value and research, I think, supports this is that when we do good case conceptualization, we also not only is it personalized treatment, the effectiveness and the efficiency of therapy is better. That we can pinpoint some things and help people move to better outcomes in a more efficient way. Maybe it's not going to take 40 sessions. Maybe it's 18 or 20 in a little shorter time frame, or maybe it's even less than that in some cases. So I think it also helps us with figuring out what the outcomes are going to be, keeping us on track in therapy. The other thing I'm going to kind of add is I think case conceptualization also helps us maybe predict some of the challenges. I think sometimes if we just think of diagnosis and treatment, we miss the fact that there are a lot of variables in people's lives that are going to either make treatment maybe more difficult or hard for some follow-up. And it lets us kind of predict that and helps with treatment adherence.
Yeah. And I think this comes up a lot, especially if I'm working with like children or adolescents, even teens, who just doing things after school, and it like the rotation that can come along with like, oh, it's football season, then it's wrestling season, then it's track and field season, or like, and it's like, oh, this has practices every other night, up this one the entire week, and it just like that then changes the way that that we're even able to meet, but it changes their routine. It changes like what is going on for them, the stress load, the how physical they're being. All of these different pieces. So like it's a very clear cut, here's a change that's coming up that we can predict. And so, hey, this works really well because you have this break in time after school, but in like 5 weeks, you're not going to have that break in school anymore. What are we going to be doing then? Because, if we're setting you up for success right now, then we're kind of setting you up for failure when you're not going to be able to have this. So what does this look like and how do we make it adaptable now? So that way come, whatever season it might be, we're then able to adapt the treatment or adapt the measure? Or are we saying, let's wait until we're actually there before we're starting? Because, we want you to be able to, we don't want to start it when it's easy. And I think we talked a little bit about that with like setting goals. Right. Don't set a goal when it's the ideal moment. One, when is there ever truly an ideal moment? But also the moment that changes, we haven't really set ourselves up to deal with those challenges. Yeah. And so I think case conceptualization absolutely helps us predict, because if we know that person, we know their interests, or we know what's coming up for them, then we can again, make the treatment dynamic and make it this fluid process that can adapt around whatever obstacles are coming, whether that's externally or internally. If it's, hey, this is a difficult anniversary that's coming up, or, I'm dreading going and seeing family, like just these different internal pieces as well. Yeah.
Yeah. And I even think of it as, there's parts that I do when I interview people that, will kind of lead into some of my case conceptualization. And a lot of it comes really, John Norcross has done some incredible work in this. He's over at University of Scranton, I believe. But his work's been like things like, how we ask people questions about, what kind of therapy are you interested in? Would you benefit more from something more direct? Do you want something that, is maybe a less direct approach, and really kind of getting their preferences for treatment. And, how we utilize that information then in understanding the person. So I use those questions early in my interview, which is could be a whole nother episode talking about that. But like some of those questions that we ask, those are the things we want to bring in that will help with barriers. Like if I ask up front, how are you going to do in therapy with me giving you between session work or homework or whatever we want to call it? How's that going to work for you? Like, is that something you think you can manage? What time are you going to be able to have available for those things? And I ask that, and then I pull that into understanding what I can do as far as my treatment and make that part of that conceptualization. We don't have the barriers later on. There's a great book I read years ago. I don't think they ever did a second edition, but the book's actually, I think, just called Treatment Adherence, and it's by Donald Meichenbaum, and Turk is the last name of the other author. It's a brilliant book, and they talk a lot about that, like how our best way to avoid difficulties in any treatment and to have better adherence is to identify what those challenges are early and make that part of our understanding of the person. Because if you have a person up front says, I'm not going to be really good at doing some of these between session work, we have to find ways to work around that to still give them that practice between sessions. So all of these little things, I think, add to case conceptualization and ultimately better treatment.
Right. With this being like such an important piece that maybe goes unseen or unused, or maybe it's just not really fully recognized. I think a lot of clinicians do this often, but they might not do it in maybe to the full capacity that they can. And, I know in our next episode, we're really wanting to break down the how, but I think there's, with this one, we were wanting to capture a little bit of what is case conceptualization and why is it important. But I'm also like, who is it important for, or who can really benefit from utilizing case conceptualization, do you think?
Yeah, I think that's one of the great parts of it. I mean, honestly, any helping profession is going to be able to use case conceptualization to help the process of those they're working with. Whether you're a school psychologist working with students and trying to understand the situation for them to make some better interventions for them, or if you're a physician and trying to help a patient, or a counselor or social worker, I think really the idea of case conceptualization really crosses so many fields, which is really, I think, interesting. And with it, again, it's, most of our professions that are helping professions, we're blending, the science and the humanistic aspects together. And this is a way to do it in a really thoughtful manner. So I guess I would challenge anybody that is working with people to start thinking about people and how these different factors in their life kind of come together in the work that we're doing. And I'm excited about next time maybe talking about some of the things. And there's a lot of models out there. I mean, there's tons of books that you can read on it. I'll share with some of the things I've written about and some things maybe, Paul, that you put into practice. But there's no one perfect way for it. I think that's the other thing. There's, I think we can share our thoughts, but there's other resources that I think people can pull together, and there's no perfect way. It's what fits your practice, and just to give people another way to kind of think about things.
So we have to be individual and unique in the way we're trying to tailor our individual and unique treatments. Yeah, that makes sense.
We'll use that as a quote.
Yeah. Well, then we hope that talking about case conceptualization has been able to get you psyched up. And we really hope you're coming back then next week as we're really talking about how to do case conceptualization. But until then, be well, stay psyched.
Well, Paul, we're back for kind of the extension of our last episode on case conceptualization. And and really kind of talking today more about, I guess, how we do it, or what's the parts of it.
Yeah. Round two.
Round two.
And, we hope that you listened in on our part one episode. If not, we'd probably encourage you to give this one a pause and go back and listen, because in that episode, we really talk about, what case conceptualization is and why it's so important. And so, as you said, in this one, really wanting to talk about like, hey, now that we know that, how do you do it?
Right.
And so, Ray, maybe starting off sharing, like, because you have quite a bit of background talking about and you've been writing about case conceptualization. So for you, if you had to kind of give a broad, a broad direction there, how do you do case conceptualization?
Yeah, it's been something I've been really kind of passionate about through my career, being able to write and present on. And, so we're going to maybe let's go through kind of the model that actually Ro Minuti and I put together, many, many years ago, probably almost 20 years now. But I want to just kind of come off of our last episode. We kind of ended talking about what we're going to talk about is not the only way. And I just want to reiterate that, I think, again, to people is, we're going to give you kind of the things that we look at and kind of the model that I often teach and present about. But know that there's other models out there. I really encourage anybody, read about different models, see what kind of fits for you. And, there's no perfect way to do this. It really does get kind of individualized. So, talking about case conceptualization, maybe Paul, what we'll kind of do is I'll talk about maybe some of the areas that we look at, and maybe we can just kind of discuss each of these as we kind of go. So it's interesting. Ro and I just made some changes in kind of we're writing right now, kind of a revision to our case conceptualization model. And one of the things we've kind of put to the front of this is, years ago, and I've shared this with you, Paul, is that when I was doing training, I would sit in on case conferences, and case conferences were always, you kind of had to know how to present a case. So it was, I have an 8-year-old boy who is presenting with a generalized anxiety disorder, who has these symptoms. And it was this very formal kind of process. And one of the things over time that I started challenging is I never understood why we don't talk about the kid first. Like, why don't we say, like, hey, there's this 8-year-old kid that's coming into my office who's really into Star Wars and Marvel comics, and he's into all these activities, but he also has an anxiety disorder, where we kind of get to understand him as a kid first, and then understand the kid that has a problem. And that will make sense when you listen to the first episode. Like, we want to understand the person with the problem. So one of the things that we kind of have in our case conceptualization, which I think is kind of unique compared to other models, is this idea of who is this individual as a person? Essentially, what makes them tick? What are they into? So we start with that humanistic personal piece, which I don't think we can ever go wrong with. So that's kind of our start point, which doesn't sound very clinical.
I think that's maybe what makes it so effective or so important, is because, we're starting with this fuller picture of, right. So when we start talking about the anxiety or the symptoms, we're seeing the way that it's impacting rather than just talking about the symptom itself. If it's impacting sleep, if it's impacting grades, if it's impacting these other areas, what were they, was there a time before anxiety where that wasn't impacting it? And like, how much of a difference is there? Has this always, right now anxiety is keeping them up, but before it was video games. So they weren't really ever sleeping beforehand. Right. So, those different pieces that can play such an important role in saying how influential is, this diagnosis or the symptomology versus, just focusing on, there's a disturbance in sleep with anxiety.
Right. Yeah. It's really getting to know that person. I think the other part that really is interesting as we've kind of evolved our model is, with all the things, and we've done episodes on this about helping use pop culture into our treatment, and how we use certain metaphors that are going to connect. If we understand what makes people tick, whether it's kids or adults, it gives us a better way to connect all of those interventions down the line, and to really, be thoughtful in the metaphors that we use. So I think all of that kind of goes together really well. So that's our start point. And then we move more into then talking about kind of the concerns. And when we talk about case conceptualization, we talk about concerns across, those functional areas, whether it's school or work or home or community, trying to look at how the different symptoms or problems might present across different areas.
I think, again, starting with the person, that can be really valuable because you're seeing them what is being taken away or what is lost.
Right.
Right. Like when you're thinking of the concerns, I guess, how nuanced do you get with that? Like, are you trying to get very specific, or is this just kind of a general conceptualization?
Yeah. I think that for the conceptualization part, I kind of try to make it more summary of symptoms and rather than listing out this laundry list of all these different things that happen. I think we have to kind of pull some things together. So it's really kind of taking all that information from that interview that we've done and the information that we get from people and really kind of summarize those reported concerns. One of the things we're writing about right now is the idea of not only asking when the problems occur, but one of the things I often ask is, tell me when you do your best. Tell me when you're not anxious, or tell me about the times when you aren't depressed or don't feel depressed. I think knowing those times are also important in understanding the concerns, because most people don't feel that way 100% of the time. There's always some times that maybe are a little better. That doesn't mean they're healthy times that they're doing it, but it's so important for us to know. We're going to have an episode coming up with John Murphy, who does solution focused therapy, and he does a lot of work around understanding where people, what are the times where their behaviors or their moods are the best. So it'll be interesting to kind of hear his take on it, because I think he does that very well. But yeah, for me, I kind of make it more of a summary. I'm really looking at reported concerns conceptually, definitely those that we see across multiple settings as being the ones that we want to really kind of target first versus, if they only get anxious in one setting and they're fine in every other setting, not that we won't want to target that, but if they have other behaviors across all settings, we want to target that one area. So that's how I summarize it.
It's almost like looking at like the data, like a one raw data point versus trying to make, distilling down good information from many data points and trying to then, formulate like, a trend rather than just one potential outlier data point or something along those lines. Right.
Yeah. Agree. Yeah. Next the next area we kind of talk about is understanding the antecedents and triggers, which is a very behavioral therapy kind of view, but definitely something important. I find knowing what those trigger points are for people when things are the most difficult for them does help give me kind of a good understanding. So really kind of having a little summary about that, I think, is important as well.
We talked a bit about this, in the last episode, but some of the value of knowing what's coming up for someone, or for identifying those particular instances of what brings this on, we can then talk about it, or we can even kind of engage with it in interventions in different ways. If we can identify this trigger, then like, hey, let's have an imagined or role play, these interactions, and saying, let's break it down step by step and or frame by frame. And let's see, like, what does this look like? And, how would you imagine this going on if this was actually in the moment? So if we miss that piece, we kind of are at a loss of like, what's the starting point? And we just kind of plop ourselves down right in the middle of it, which can then almost be disorienting if we don't have that direction.
Yeah. And it's interesting. I just had a case I was with the other day that we were talking to the individual, and it was an adult and very severe anxiety. And it was interesting because primary anxiety is essentially about functioning at work. Like that's where the primary, that's what she came in for. But as we talked, there were other kind of these peaks of of anxiety that happened that, which was kind of those reported concerns when they happen. But the interesting part is with the antecedents is I think it also helps us distill down to, in this individual's case, it wasn't the situations that were the trigger or the antecedent. The antecedent was the thought that she would be criticized. So when we think about this more in depthly, it's, so for me, like if I was just treating her work anxiety or just treating her anxiety driving or just treating her anxiety when she, has to help her daughter with homework or whatever it might be, those individual situations, they don't necessarily matter. The antecedent is she's afraid she's going to be wrong or criticized. That when she gets that thought and gets that feeling of, oh my gosh, I'm putting myself in a situation that this could happen. It doesn't matter what the location or where she's at, it results in the same level of anxiety. So I think we got to dig into those antecedents a little bit.
They kind of help to uncover maybe some of the more like core concepts or the core belief systems there that drive the anxieties that again, you're missing if we don't take the time to focus on it.
Right. And in some cases we will go, I think, down to that thought. And I think other times maybe it is just situational. I've had kids especially who, transition times are difficult for them. And it really doesn't have any necessarily thought tied to it. It's just that the act of transition is overwhelming for them. So I think we just have to look at them a little deeper and, there's tons written on antecedents and triggers, but it's definitely something we have to think about as part of our conceptualization.
Yeah. Well, and I think this next step you were sharing with me earlier, and I'm interested to hear how this plays a role and maybe kind of hearing like the application piece for, I think it was developmental considerations.
Yeah. So, it's interesting. So this, again, this is not unique to us, but, really understanding, and this isn't just for kids. So even with adults, understanding developmental considerations, that's not like, okay, when did they walk and talk? Like, that kind of development. But we really view it kind of theoretically in that, we have a lot of wonderful theories in development that help us understand people, whether it's something like Piaget's cognitive factors and really kind of saying, okay, let me understand this person. Is this a person I need to be really concrete with in my examples? Or is this a person that's going to want this challenge and move up into these kind of higher thinking and higher order thought processes? That's a developmental consideration. It's not about intelligence, but we just have to understand the person. And that makes, again, when I understand that, there are some people I stay really practical in my interventions, and some we get pretty heady about what we talk about. But thinking about that lets me help tailor that treatment. But also things like, Maslow's theory of hierarchy of needs falls into that. I really love Erik Erikson's work on, these developmental conflicts and kind of where people are at, and have written a little bit about that over time is that, when we think about things like Erikson, they're always talked about in these stages. And I always kind of viewed them more as this fluid kind of process. Like, I don't think we just hit these stages and move up. I think we're always vulnerable to fall back a few stages at times. When I talk to patients, I always use the metaphor of skiing. And I'm like, if you're skiing, you can have developed to a point where you're a good skier and you're going down the slopes and you're kicking your skis back and forth and you're doing all kinds of great slides and throwing snow and doing all those things. But as soon as you get to a mountain, that becomes overwhelming. We all have the tendency to go back to these old snowplow behaviors, how we first learned, like we go back and we revert to an earlier stage of our development. When we think of developmental considerations, that's kind of how we think about it, is that there is a little flow with it that we have to kind of pay attention to. With Maslow, I think Maslow's things I mentioned, that is, I think, really one of the more important ones that we should consider, knowing where people are at in these basic needs. If we have a child that's depressed, they're also homeless. We really got to think what conceptually with this person, what's the things we need to really target first. And so, yes, when we think about development, that's kind of how I use it. What are your thoughts on it?
You just shared so much, I think really good information. I'm sitting here digesting it for a moment, but I think it allows us to reflect back, what is the thing that truly helps this individual? And even if I have I like your term heady. I oftentimes can get heady, I think, in this sessions as well. But if there's someone who I can have the best, really dense concept for this and trying to share this with someone, but if they're not there and if they're not really, interested or seeing it and viewing it in that way, then it's not a good or an effective treatment process. Right. And I keep coming back to this, how do we do the thing that helps? So the child who is homeless, if we try to then talk about talking about resiliency and talking about, how do we try to adapt to really challenging circumstances versus, hey, let me be a more accurate identifier of threats, but this child isn't, in a threatened situation. Yeah. So, to try to dismiss that or to try to challenge that, that's not an effective tool or resource in that moment. So, it goes back to that dynamic tailoring idea or concept where, we are really trying to fit and meet the person with where they're at. And I think developmentally, if we can keep those, we went through our developmental classes for a reason. If we can keep those theories in mind and we can really try to apply them, then we're not just sitting in a classroom having to take a test on Piaget or Vygotsky's or Freud or all of those theories, but rather we're kind of seeing them come to life and seeing what does this actually look like in the therapy setting.
Yeah. And, I think they're doing training with people. They're always like, well, is there a rating scale for this? No, it really is just, this isn't trying to find the perfect science. It's trying to say, okay, these are just thoughts I have to think about for this person and consider. And it really is, I think, doing this, and I was lucky in my training that I was told to do this very early, was it's really changed how I think about things. I just had a teenage guy that I just saw who, and I'm going to go back to Maslow. That seems to be a really go-to for me sometimes. But, he's a kid who's really struggling with some anxiety and depression. But, he's been it's 3 or 4 therapists before me. I'm, I guess number 3 or 4 or 5 here. And he's and everybody keeps treating the depression. And conceptually with this kid, through asking questions he's sleeping 2 hours a night. He's video gaming all night. And I know that's, that happens, but we have a kid who's sleep deprived. We have a kid who's physically, his needs are not at a level that me asking him his thoughts about anxiety and depression aren't where it's at. We have to talk about sleep hygiene with this kid. And I don't want to say it was a mistake, but I think where therapy didn't work for this kid is without thinking about those needs that he has from a physical standpoint, which I kind of lump in this developmental piece where he's at, is we can't get him to start thinking about his thoughts. We had to really sit down. I had to talk to parents and say, listen, we need to really start with some basics here. Let's start with just some sleep hygiene and let's get him up to 4 hours of sleep a night. And how do we regulate this? And how do we do these things? And getting him on board to do that. And, maybe 4 hours don't sound like a lot, but it's better than 2.
Double.
Yeah. And we'll hopefully get to more than that. But, my approach was, I can't treat the depression if we don't get him to a point where physically he's in a better place. And I'm going to work with you on that first. Now, we're only a few sessions in. We're not far enough that can predict outcomes, but he is sleeping more. Actually, rather than 4, it jumped up to actually about 6. We have really, really kind of specific behavioral things in place. His mood's already improved. We've never talked about depression or anxiety yet. That's why I think these things are important. It lets us think about things that ultimately, if we don't address or if we don't think about, might impact our outcomes.
And it's funny you're talking about sleep. I had someone that I was working with even just last night. And it was actually, it was him and his wife. We were talking about what are some healthier just lifestyle changes that can be made. And sleep came up, and she was sharing her concerns about, him staying up too late. Yeah. And, as he was talking about this, he was talking about how, in the morning, he always has, he's always feeling groggy. He's always just not feeling good. Right. And he's really frustrated and upset with last night, him. But by the time he gets to that, the next night, it's always this, I worked so hard for everyone else all day. Why can't I do something for myself? Yeah. And one of my comments back to him was, well, sleep is something for yourself, but it's not you in that moment. It's morning you, morning you that's always ticked off at night you. This is something for yourself. Both of those are the same person. We need to really connect that and not have it feel like I'm not doing anything for me. This is a really good thing to do for me. And this is me really taking care of myself and putting myself first. Right. And he kind of stopped and took a moment there, but it's that understanding that just said, if I was oh, well, hey, get more sleep, that's not going to be the effective treatment approach without really understanding why. And if we can connect some of those, the barriers there, make it then more effective for them.
Yeah. I mean, and it's, again, all of this kind of ties together for people. And it's, we've all had these developmental classes, let's not put them to waste. We paid good money for those classes. Let's use that different. So I think using that, is really helpful. And, we then kind of go into the kind of ethno-racial and cultural considerations that we have to kind of pull into therapy as well. And, this is kind of an area I think just keeps evolving for us as we get better at understanding different factors that are, people are affected by. And this covers for us kind of a broad piece of it. It's really understanding culturally, just simply, beliefs about mental health could play a part in that. Are there different things in their cultures that are important for us to understand when we're thinking about treatment? But also, I think what we've done better is understanding the experiences of different groups and different, especially marginalized groups. And how that impacts how we do treatment, and understanding that, we can have different people from different racial backgrounds, gender, whatever it may be, all be in the same situation and all have very different experiences. And that's really what we're trying to target there. It's, I feel like I'm learning so much always in this area, but, just even, and when we use kids for an example, I've been in situations where I've treated 5 kids in the same high school at the same time, and all of them being of different, either racial backgrounds or some type of, cultural differences. And they all had very different experiences based on their background, and having them teach me about that, and really trying to understand that, it's just been so good at really helping connect with them, but also helping me view how we're going to use interventions differently. And I'm excited. We have an episode coming up here soon with a guy who I had an opportunity to see. His name's Ryan DeLapp, who I think is doing some of the best work in this area. He taught me so much in just a few hours of training, doing a training or workshop with him. I'm excited to get more of his view on this, but definitely something we have to, think about, and really think about those experiences that people have that are different than what we experience.
And we can probably I'm really excited to hear from Ryan. I've heard some really good things from your training with him, but even just my own thinking back to diversity courses, and how that just being aware of the privilege, or just the privilege that certain individuals have, which then means that other other individuals are at this disadvantage.
Yeah.
And if we just take those things for granted, especially if we're a therapist and taking something for granted of our experience, then it discounts and discredits and really can make someone feel marginalized. And, if we're really kind of like that idea of like feeling smaller, feeling like, having to fit a certain description. And like, if you're not, then you're less than.
Right.
And that's not really an effective area for growth. And so through developing a really conscientious understanding of that, again, giving that person permission to be themselves and letting them be the educator. I love the idea of, they are the expert in them. Yeah. So, let's listen and learn from them, right. and their beliefs, their views, their experiences, all of those different pieces. So we can get a better understanding of what's the specific perspective and lens that they're viewing things through.
Yeah. I mean, I think it's absolutely important, and really, I think we're seeing better information and better ways of approaching, any type of cultural differences in treatment. I would say my training was mediocre at best when I was kind of going through. It was a lot of theory, but it was like, oh, here's what you should know about, these different groups. But really how that applies in session and how those different understandings can influence treatment. I think that's what we're getting better at. And I know that just taking the time to understand the experiences that people have and the perceptions that come from that, and having real conversations with people about it. I think it's so easy to just blow over it, and to not have the conversation. And it might be uncomfortable. But to really say, like, listen, I don't know a whole lot. I need you to help me understand this experience. And how is your experience different than mine? And really listening to that. I don't know. I think it's made me a better therapist. And that doesn't matter, what racial background, cultural background, not any of that. I do it the same with everyone, even if it's, somebody who's a white individual who comes in, they have a cultural experience. They have a racial experience. We really need to look at this across everyone that we work with to really get that better understanding. I do think we're getting better at it. Got a long way to go, but it's something we have to think about when we're conceptualizing and helping really understand people.
And it's funny. I think my graduate program did a really good job with teaching, like showing diversity, privilege, like just like those different cultural consideration pieces. Yeah. And probably, one of the courses that just really stands out to me of like that opened up my eyes. One, to just like, I knew about privilege, but that was the one that actually made me understand privilege, I think.
Yeah.
And so being able to then, I think it makes us better listeners, and it makes us, we then are able to cut through a lot of our biases that we have and just, really hear what the person's experience is instead of trying to color it or shade it in our own personal perspective or, what we just assume their experience was. Yeah.
Yeah. It really, it's an area I think we can continue to look at. And again, I'm going to keep throwing Ryan DeLapp's name out there. I think this is a guy who he and his wife have been collaborating on this model, and it's exciting to see. It really puts some real meaning in training on how we use this stuff. And essentially, your experience is definitely different than mine. Just generationally, where when I was in training, like I said, it was part of a curriculum because I think it was thought to be that was the right thing to be part of a curriculum. I've gained more probably in the last 5 years in this area of just doing my own kind of, going to workshops and reading and than I ever did in graduate training. So I look forward to seeing more how this evolves with how we do treatment and seeing some real practical things be put in place to make it meaningful.
Absolutely. Yeah.
So next kind of area, I guess we go into is wellness and resiliency factors. So we also, when we're trying to conceptualize a case, You can't just talk about the problems. Like, what are the things that are going well for the person? What are things maybe that they have in place that are going to be, good factors to build resiliency? Maybe that's they do have good connections with people, or they're involved in a lot of activities, or maybe it's a supportive family. But even, things like maybe there are people who do get great night's sleep, or they exercise, or they eat a balanced diet. All of those wellness things, I think we have to take into consideration. And sometimes there's little gems in those resiliency factors that we can really pull from and I think make part of treatment. So I think knowing all of, kind of what's going well for people is important to ask.
And I think it can also be a really valuable, lend some valuable insight with how severe could this actually be? And they're just adapting to it well because of these resiliency features and factors. And so someone who has a good sleep routine, who's working out, who has a good diet, and they are then struggling with this in a way that maybe feels like it's only presenting in certain areas, but only because they're taking care of themselves in these ways. Right. And like, there could be more severe, significant things happening that just aren't, coming up to the surface that, if we just discredit or discount that, then we might not be seeing the full picture. So kind of the value and the resiliency and the strength-based aspect, but also kind of like, because they're adding, then we don't, just because they're adding doesn't mean that we're taking something away. Right. There can both be these positive features and negative features that are present. And
I think it's definitely, we use the wellness and resiliency factors as the term, because we don't want to just ask people, like, tell me what your strengths are. It's just so superficial. No one ever gives you, so
caring.
Yeah, right. It's just this laundry list. And I don't want to know about that. I want to know about, like, tell me about what you do that helps you take care of yourself. What are these good things that happen? Essentially, I'm treating a physician right now who works, 12 to 14-hour days, tough schedule, and great physician. And, it was interesting because I said, tell me a little bit about what do you do for wellness? What's that look like for you? What are the things that you think help things be better in your life? And it was funny because her first thing was, she goes, you know what? I come home every day, spend time with my kids, and I spend 2 hours playing Call of Duty. Didn't expect this. So she's like, she's probably, I'd say mid 40s. And I went, and I'm sure I gave a funny look, and I went, what? And she went, yeah. She's like, she goes, I need something that's mind numbing. I need to just take a break. I need something and she's like, I find that it's a little escape for me. And, so maybe the first time in a long time I've wrote Call of Duty as a wellness factor for her. But for her, it was that finding a way to just let herself reset. And it was an important factor that we had to, and she's like, listen, I've tried relaxation. I've tried going to the gym. She's like, I run all day long on my job. She goes, I seriously want to sit down and do something that's just, I don't have to think about. It's, I think she used the word, it feels very carnal for her. It's like this, really just, but I think it's interesting. So when we talk about these things, they're unique to people sometimes. I don't know that I would have thought of that, but for her, she's like, man, when I reset, then I'm okay. And my husband and I get some time together. And then I get to sleep. I get a good night's sleep. And she has this wonderful routine that is great for her. And I think we have to, like I said, we can't make judgment. Like I said, I probably made a kind of a little bit like, okay, that's the first time wellness was in Call of Duty came in the same sentence, but it was unique for her and an important fact for her, something she needed to have part of her day. So I think we have to let it be a little unique.
Yeah.
So I guess on the other end of the wellness pieces, we also include in kind of what we think through is barriers. What are the barriers to progress? What are some things you see with people you work with?
A lot of times I think I like to think of it in terms of internal barriers and external barriers. So like barriers in terms of if I have a thought process that says this is how it's always going to be, then we have a bit of that self-fulfilling prophecy coming in, or we get stuck in these negative feedback loops without challenging them. So we are kind of putting these barriers or these limits upon ourselves. And it's then working to really it's an important piece to understand, because we can put, all of these different interventions in place, but if I don't think any of them are going to work, I'm not going to buy into it.
Right. So
that being a barrier versus the external barriers, which might be, changes in environment, changes in routine, certain individuals that are, that end up going back to triggers or just things that we know that are happening in their lives that are going to be challenging.
Yeah.
I can think of one individual who, they know that they're going to lose their job here soon, just kind of like they're about 90% confident. And that is now a barrier because, well, one, insurance, they're going to lose their insurance coverage. They're going to lose, some of that. So we're talking about how do we adapt? How do we kind of prepare for this? But, that is going to be a huge change and a barrier for them to make progress. And so it's, that's something that is external. They're not, they're not internally, I'm not going to be able to keep my job. It's like, no, that it's unfortunately they're going to be laid off, not fired, but it's something that is a real part of their lives that they're then having to adapt with. So I think of barriers in that way, because I think then the way that we try to intervene with them or address them can be, again, more tailored or unique.
Yeah. I think barriers come in all different forms. I mean, it can be from work schedules to finances to everyday life, transportation, all of those things can kind of get in the way. So, again, knowing about them, thinking about how they affect treatment. That's really why we put it in this piece. I never want to react to a barrier. I always want to be proactive with a barrier, if that makes sense.
And I like, I oftentimes will talk about this with parents too, like when we're trying to kind of talk about like, okay, like, hey, working with a child, and then like trying to say, how do you adapt this in the home? And I recognize I have an hour on, I have, 40 to 50 minutes of uninterrupted. We're just sitting down, we're focusing and we're talking, and it's so effective in here. And then when you get home, your other children are going, you're running around. Like, these are different environments. That is a barrier, So you are not going to be as successful in this as I might be because of those factors. And so how do we have to keep that in mind? So a lot of times I'll kind of joke around. I was like, hey, I'm going to talk to you about this like it's the ideal. I realize easier said than done. So I want to first get it out there as a concept, and then let's talk about how do we apply this specifically for, what this could look like, or how do we just make the best out of it that we can sometimes.
Yeah, I agree. It's the same thing for me. I mean, any way we can kind of approach it, whether it's parents or the patients themselves, I think it's important. Yeah, I think that leads into even the next area, which is readiness to change factors. And again, that's not unique to us by any means. I love readiness to change research that's out there. It's been something I've kind of followed throughout my career. But really, this idea of where the person is, meeting them where they're at, and just because everybody else in their life wants them to be at the action phase doesn't mean they're going to be, and we can't jump to that either. So, nothing here out of the traditional readiness to change model, and just kind of thinking about that and trying to find where the person's at so that we can maybe treatment match a little better.
Yeah. And I think we've talked about this in other episodes, the stages of change. And, if we're trying to push someone, like you said, into action or even into preparation when they're really even in pre-contemplation right now, that's not going to be effective.
Right.
So again, such an important feature of meeting the person where they're at, and how do we help them transition so that way we can get to maintenance and then being successful in maintenance. Yeah.
And then the other piece we add in our model is we have relevant assessment data. And this is really, I think, something that it really depends on who we're seeing. we might put some unique things in this area where we're kind of thinking about things that maybe came out of the interview that didn't fit anywhere else. But we also think of things like rating scales. Maybe we've given some, like a PHQ-9 or something where we're trying to look at some symptom severity. That's information we kind of put in this section and kind of think about as how it developed out.
Do you feel like, is that also like applicable in terms of like grades or kind of like workplace, like work review, like performance reviews and things like that are going on, not even necessarily in the therapy session or setting itself, but like assessments that are going on outside that they're being kind of held to?
And I have to revise this chapter I'm writing, Paul. I didn't think about that, but I like that.
Yeah.
I think that's a great point. I think that data piece, right? Yeah. I think grades fit in that, right? Mm-hmm. I think there's, in some ways that's such a great functional assessment, knowing what we're seeing on their grades or work performance I think any data that helps us understand the person better, we should put there. I think sometimes, I think too psychometrically, and I think of rating scales and like tests and things. But I think that's an excellent point. I think I would encourage people, anything that you have like that, we should be looking at and considering if we have access to it.
And I always love like when, especially again, children, I think have an easier time with this just because there's more adults involved in their lives, but behavior charts, if they're ending on green more often, if they're ending on yellow, red, or, hey, we put a bean. I have one family that we talked about. They have a successful morning. They put a bean in a jar, and once they fill up the jar, then then they earn something. And it's, hey, how many beans did you get this week? Right. And so like again, it's an odd assessment scale. That it's the bean assessment scale, but it's an important one.
It's an important one, and again, it doesn't have to be these big nationally normed scales. Sometimes data is just good data in real time. But we have to always consider those things. So with case conceptualizations, we had all these little areas of information. We kind of maybe now move into more this wrap up of it. And what do we do with all these variables that we've talked about? And, so kind of the goal of case conceptualization is this concept of developing a working hypothesis. With considering all these things, what do we think is happening with this person? And why it's happening at this time under these circumstances, that kind of big kind of thought or big question of, why is it going on and how can we summarize it so it can help us develop treatment goals? I love the term working hypothesis mainly for the first part of it, the working piece. And I was always taught in my work that it's a working hypothesis because it is change. It will change. And sometimes after our first few sessions, we get a hypothesis and we move down a direction and maybe treatment's not going the way we think. And we have to go back and revisit that hypothesis and make adjustments to it. And it is a fluid piece. And I wish I could say I am right every time on my first attempt with working hypotheses, but I'm not. I think that's the part of therapy. We take information, we make the best kind of hypothesis we can, and then we use time and data to modify that and to adjust treatment as necessary.
Yeah, and I think as a clinician, like, to have those aha moments, I think that feels good for us. And, if we're right every time, it makes those aha moments much harder to have.
Yeah.
And there's other times I know when I've been working with someone for quite a while and then they drop a bombshell on me. It's like, oh yeah, no, this has been going on for years. And it's like,
yeah,
well, this changes everything.
Right.
So we have to throw the old hypothesis out and like, we're kind of, well, not that, but we have to update it. We have to adapt it. And sometimes it can skew things drastically. Substance use, I think, is one that a lot of times doesn't get disclosed initially.
Right.
And then later on down the road, it's like, oh, I get high every night.
Right.
What?
Right.
Why haven't we talked to, I didn't want you to tell, I didn't want you to tell my parents, or I didn't want you to tell anyone. It's like, all right, I understand where you're coming from, but man, that's a really important piece that we didn't have now. And so, again, like it's putting everything together and updating as needed.
Yeah. And I'll say you kind of said something and then took it back, was like that you scrap it. And I think that happens sometimes. Yeah. I mean, I don't think that happens often, but I remember a case years ago where I had a gentleman I was seeing, and I mean, we kept modifying the hypothesis, just couldn't get to it. And after we were probably maybe 6 months into treatment, and he automatically discloses that he had some significant physical and sexual abuse when he was a child that he never disclosed in earlier sessions. We scrapped a lot. Like, I mean, it was a complete, and I said, like, wow, okay, like now it makes sense why we haven't, maybe made the progress we want. We really need to address this a different way. So I think it's okay to scrap sometimes. I think sometimes we have to. I don't think that happens often. I mean, I probably on two hands in 28 years can't think of. Yeah, I don't think I could fill two hands of cases, but it does happen.
Yeah, well, and maybe I should have said scrapping the hypothesis, but not the conceptualization, because all the other information I think is really valuable and important, but
there you go.
It might just change how we put it all together.
That's right. Yeah, you're right. All the other stuff's still important, but this new variable may have changed it, the hypothesis completely.
Yeah.
And so with all of this, we're really trying to get this hypothesis, which then leads, I think, to our last kind of two pieces. And that is, is there a relevant diagnosis for the person? And while I don't think diagnosis drives treatment, I do think diagnosis helps us understand and bring in some research data to help develop our treatment. And then really looking at how do we take this hypothesis to form good goals and determine how frequently somebody needs to be seen. And we could probably, Paul, do a whole episode on how we use data to determine the level of service somebody needs. I mean, I think that's really, over time, I think we get better at that. Younger clinicians, I think sometimes that's at least the feedback I get from people is they're like, should I see them every week? Should I see them every other week? Should it be twice a week? Like, knowing that level is sometimes a hard decision. I think that gets easier when we go through our career, but so the end of creating a conceptualization is taking the hypothesis to now drive treatment goals, treatment plans, and interventions.
Yeah. It's funny. And I agree. I think we probably could, but there, as you said that, there was a past supervisor that I had, and he would always talk about acuity. What's the acuity for, spend some time, look over your caseload. His one thing that he would repeat was, is this client receiving a disservice by not seeing you as often, or are they receiving a disservice by seeing you too often?
Yeah.
And really to and that, whether that's in safety, whether that's in, the availability for progress, the availability for them to actually take these things and put them into place. And so, it is something I think that develops over time. Yeah. But it's funny, as you said,
that's a wonderful question though. Yeah. I mean, I think, I think that, because it can, what is really the right balance for this person? And again, I don't think that's disorder specific. I know there's research that would maybe indicate it should be this amount of sessions or this often, but it is really individual. I have two people that are really very close in what I'm seeing them about. And I have one that I see every week. We need to see every week. If we go beyond that, it's not a good fit. And I have the other that we see about every 2 to 3 weeks. And that individual needs the time to practice what we work on. And a week's not enough. So when they come back into session, they're like, I don't know if it's really working or not. So that spreading it out gives them time to really, and they're great at it. They're the ideal person to go and do the interventions. They're following through on everything, but they need the time. And it's so really, making that decision based on what's best care. And I like that question from your supervisor. I'm going to remember that.
Yeah.
So with all this, how do we put this stuff in practice? So it sounds like a lot of information. And so we are going to, just to kind of call out for those of you who are really interested in this, if you go to our website, on the first page, there's a little area that says, sign up for the practice squad, which is just kind of our term for those of you who listen. And if you go in there and enter your name and email, we will send you, we actually have a case conceptualization worksheet that is something that continually evolves, something developed by me and one of my colleagues. And I would be absolutely willing to share that with you. So go online. If you put your information in, we'll send you that worksheet. That really is something just to help people who haven't done conceptualization, to help organize your thoughts, to help you get thinking about cases differently. As people evolve in case conceptualization, I think you don't necessarily have to have a worksheet to fill out every time. I like using it when I do supervision with people, because it helps me then kind of look at their thought processes. But I will say, early in my career, I used something similar, and we've kind of said morphed it into a whole bunch of different areas now. But feel free to use it. It's an easy way to just take this information, jot some thoughts down as you're going through your interview, and help you kind of pull everything together at the end. So feel free to download it.
Yeah. And, I think this is an episode that might be worth like a re-listen. Like I think like each of those different steps and stages, like to go back and like really just kind of sit with each, maybe, have the worksheet there.
Yeah.
We kept it at the end so that we had to go back and re-listen, but no, to really kind of stop and share like, hey, like what is, what do each of these stages really represent? And to pull back on I think from the first episode or the part one, is this something that works well with me, or is this something I'm looking for a different way of conceptualizing? How do I know? And, or do I adjust and adapt this to really kind of be a tailored fit for me? So I think a really valuable resource, and hoping that they take us up on it.
Yeah, absolutely. And we will, over time, if some new references we're working on come available, we will get them on the website and put underneath this episode. Some of the things like the chapters we're working on are currently just in progress. So when that comes available, keep an eye on it. We will post them on there. That way y'all can take a look, and I will put some other books that are not our model that you can take a look at, because there's a lot of great work beyond what I've been involved in this area. And I know they're all valuable resources for me. So hopefully y'all can check them out.
Yeah. So just so much good information. And, if after listening to these 2 episodes, you have any doubts, then, also go listen again. But case conceptualization, just an important piece to be, not even just an effective clinician, but just to be an effective, provider of support and services for others, because it helps us really get in touch with the individual. So we hope you enjoyed this episode. We'd love to hear that feedback. Please reach out if you'd like that worksheet. But until next week, be well, stay psyched. The information contained in this podcast and on the Psych to Practice website is intended for informational and educational purposes only. Nothing in this podcast or on the website is intended to be a substitute for professional, psychological, psychiatric, educational, or medical advice, diagnosis, or treatment. Please note that no professional-patient relationship is formed here, and similarly, no supervisory or consultative relationship is formed between the host, guests, and listeners of this podcast. If you need the qualified advice of a mental health professional or practitioner, please contact services in your area. Similarly, if you need supervision on clinical matters, please locate a supervisor with experience to fit your professional needs.